Woohoo! We are here. Hello, everybody.
Hello.
Out there on Facebook, YouTube, and the people in GoToWebinar. I expect
The broadcast is now starting. All attendees are in listen-only mode.
she's there now. Okay, great.
Now they're there.
Who was that lady? And is she getting royalties for talking when the webinar starts? That's what I want to know. Hello, Alicia. Hello, Jennifer. How are you?
Hey.
We're doing pretty good.
A
Little bouncy tonight.
Yeah, we're a little bit jumpy. It was a little weird day today. Was it raining in your neck of the woods today? Was it raining like cats and dogs where I was?
No.
No, that's tomorrow.
Our storm came in last night. We're supposed to be here at midnight, hit at 11:30, and the world kind of went whoosh, and then it was over. 30 minutes.
Can you do the sound effect again for us?
Whoosh. Actually, it was a little whoosh. It wasn't a complete circle. It was whoo, not a whoo. Yeah.
Awesome. Well, let's get going. I think everybody's getting in there. Let us know in the chat if you can see and hear us with a 1. That would be awesome. So I know that we're communicating well. And welcome to the Certification Coaching Q&A webinar for April 2019 with CCO.US. Along with me, Miss Alicia Scott. Credentials, please.
CPC, CPCI, CRC, and soon to be another one at the end of the month, maybe.
And Jennifer Saunders. Credentials, please.
CPC, CPB, CPMA, CPPM, and CPCI.
And that's why you don't see them in the webinar box if you're watching, because she can't
Yeah.
fit them in there. I just wanted to show everybody that I did not just pull these people off the street to help me do this webinar, and that they actually have some credentials there that could make them experts in this thing. So
They should come
we're
up
gonna
with
get
a
started.
dot for extras, you know.
Yeah, right. A whole bunch in brackets or something like that. So we are going to go to the next slide there, Alicia. So if this is your first time on the webinar, we're going to tell you a little bit about what this webinar is all about. Number one, we want to welcome you to the CCO community. And this is a general webinar about all things medical, business, certification, medical coding, billing, and practice management related. This slide, for those of us who have been here a long time, has probably been etched in your brain. We cannot hear you, but you can type a question in the chat at any time. Our team behind the scenes will try to answer it or save it to the end. And please stay to the end for a giveaway, which we're going to talk about here in a second. Alicia, we got something ready to go with a survey for everybody. How many?
You want me to do the survey?
Sure. That way you're always in control. How many CCO webinars have you attended? Let's find out. Is this... Go ahead, Alicia, you can read them.
We have first time, woot woot, because I'm into sound effects tonight. Back for more. 1, repeat offender, 2 to 5. 5 to 10 is liking it here at CCO, and 50 to 10% CCO frequent flyer. And let me tell you, right now, more of you are there, so that's really cool. I can still see people coming in slowly in the attendees on my end. So let's see, we're at over almost 80%. So I'm going to close the poll. Here we go. And share. And it looks like, is it sharing for you?
Yeah, yes. First time, woot woot, 30%. Back for more, 0%. We have no first timers. That's interesting.
Yeah, because
we do 30% first
time, 30%. No, one, just one only.
Just one.
Okay. Sorry.
Yeah. Clarification.
I'm trying to figure out how come I only see 15. Yeah,
I know. That's what I was thinking too. 20 some people. Okay, I'm going to hide this one.
Yeah.
Here we go.
Well, welcome. Thanks for joining us. First of all, GoToWebinar is acting up a little bit tonight. We normally see hundreds, and it's definitely below 100, and people are just kind of slowly coming in there. It's kind of strange. Anyway,
maybe it's the weather.
It does say it started on everybody's control panel over there at organizers, right?
Yeah.
Okay.
Orange, but yeah.
Sounds good. We're recording. Okay, so great. Well, we're basically this for the first timers. It's an introduction to CCO.US, our news and recent graduates, everything that's going on behind the scenes here at CCO.US. And then we've got some prepared questions that Alicia and Jennifer have prepared. So Alicia, tell us what you're going to be doing tonight.
One of the questions that came in that really piqued my interest, so I grabbed that one before anybody else could. Exam questions on disease, and I'm always talking about that. So we're going to talk about. They wanted to know what to look for when they're going to take exam questions regarding disease. Another one is coding for transcatheter aortic valve replacement, and this was the TAVR or TAVI, or they said, or Watchman. And so we're really going to talk more about Watchman. And then portacath, just the particulars about portacath, what they are, and how they're different than other types of ports and things like that.
Cool. And Jennifer.
Well, I had a question come in about a particular state that's having a problem with some of their pregnancy ultrasounds getting denied, and then Medicare edit issues for a critical access hospital, and then what are some steps when you get that claim denial? So what can we do?
Great. Thank you for doing that for us, everybody, the two of you, and preparing that for us so we can get some nice, strong content out for people.
Boy, did you see that message
Yeah,
that just came through? Everybody thinks we start in an hour. That's why they're not
really
people here. They said they just got their email that says it starts from 9 to 10.
Oh, interesting.
Guess we'll have to come back.
Yeah, you're right.
Talk for
Actually, I'm
that
looking
long?
at it now.
Yay!
Didn't even occur to me to look.
Uh-oh.
Thanks, Phyllis.
I can do a replay. That's the great thing about this.
That's right.
So I'll figure out how to do that. So I'll think about that when we get going. All right, our agenda, Alicia.
Well, we usually talk for about 60 minutes, and we've been doing this long enough that we've got that pretty well pegged. So we'll go through our prepared questions, then we're going to draw for a prize. So stay till the end. Afterwards, after everything's done, what we're going to do is you can submit some questions and we'll take those at the end. So you don't have to stay if you don't want to. If you want to stay with us, you can. You can ask questions anytime you want. And again, just put them up in the chat. If you're joining us on YouTube and Facebook, Boyd or Sylvia and I think Lori and them behind the scenes will grab those and add those to the end. But if you have a topic that you think we can't do off the cuff, or you want a little more investigation on it, go to the cco.us/topic-request. You see that there in the blue. And this is where we get the questions that we're doing tonight from these topic requests. So again, anytime that you have a question, let us know. We love doing the research on them. Make sure you stay to the end for the giveaway. Do you want to tell them about the giveaway, Boyd?
Yeah, sorry. At the end of this, I'm just trying to figure out what we can do to all the people that are missing. I'm feeling for them. So a giveaway, we have a Blitz video package or a 1-hour phone session or a 1-year CCO Club Basic for a prize. Those one person who wins tonight. So stay on the webinar till the end. So you have to be here in order to win. So we'll draw from everybody who's attending here today. Yep. And you got really good chances right now.
You got much better chances now because there's normally hundreds of people.
Maybe just have to redo everything. We'll just start again at 9. How about that?
Yeah. So we do give a CEU for this, but it's not instant like we used to do in the past. AAPC, we've changed some things, the way we work with them and they work with us. And so everything has to be completed and then submitted for this particular webinar. And again, it's free. The content is free, and then you can come back and get that later. You can join our CCO club. And if you want to know more about that, just go to cco.us, and there's lots of FAQs and information about that. Oh, we get to have another
poll.
Okay, let me grab it, because what is your status? Here we go. I'm launching the poll, and it says looking at medical coding as a career, certified, and looking for a job, employed, or improve my current job situation and earnings. So this is really good, because this is hopefully going to grab a diverse group of everybody. So this helps us find out what we need to provide for you, right? I think that's a good way to say it, or if you're needing education, or if you're just wanting to improve your skill set. So we're already at 86%. Man, you guys are fast tonight. So I'm going to go ahead and close the poll. And there we go. And I will share it now. And it looks like, wow, okay. So 23% of you guys are looking at medical coding as a career. And we're very happy with what we do, so more than welcome to share what we know. We're certified and looking for a job. Not as many people. 32% is employed, and 26% are here just to hear us talk. Is that right? We have fun doing education, so that's a good thing. Let me hide this poll and be ready for the next one. We have some graduates that every month that we do this, we like to tell you about who has graduated. I didn't look ahead of time to see how many that we have, but
3 slides and a little surprise at the end.
Oh, okay. So do you want to go first, Jennifer, and name off these, or do you want me to?
Sure. No, I got these are all CPCs who pass the exam using mainly the BAT and some various techniques that we have. Rhonda Warenberg, Kimberly Serrano, and Julie Grell.
I have to say, Warenberg, that's Warenberg Theaters. It's got a little, I almost wanted to say Warenberg, but you wouldn't recognize that theater thing. Elizabeth Boggs got her CPMA. Wow, that's great. Melanie Bleem, CPCO, which is compliance. CPMA is auditing. Billing, we have Jamie McLaughlin Bearden.
That's one of my students.
Elisa Marcus got the CRC, and so did Teresa Bishaw, I think is how you say her name.
And then we have a CRC of Stephanie Myman, and Tiffany McKenzie got the COC.
And there's a surprise? Is this a surprise? So not only do we like to let you know who's passed recently, and we only know that because they have let us know, but we have people that write in to give their testimony or what helped them. We recently launched our Prime, CCO Prime, that allows you to get a course, and then once you finish and complete a course, you can pick another course. So you pay an initial fee and then a monthly fee that's, I think it's getting ready to go up, but it's still like $45 or $49 a month. You can stop anytime. But it looks like we have our first Prime member that passed the CPC on her first try. Thank you guys. Wash and repeat, going after CRC. That's what we didn't really coin the phrase, it was already there. But so CPC, and she just keeps going, and she gets to keep all of her content for the CPC, and now she gets to pick the CRC. And so we have a lot of courses that you can choose from. Then we have, thank you so much for the Blitz course. They were crucial in helping me pass the CPC exam. Oh, Rhonda Warenberg. I think that theme, Warenberg, is running through my head. Thanks, Rhonda. And then Elizabeth said, I just want to tell Chandra thank you, because Chandra is one of our SMEs that had been with us for a long time. The CPMA Blitz helped me pass my second attempt at the CPMA. I took a course a year ago, and the Blitz was just what I needed to review and organize. I took her advice and looked at the OIG work plan for 2019. My first attempt was in 2018. So the OIG would have a different work plan this year. That's correct. Sure enough, podiatry is on their 2019 list, and there was a question on this year's CPMA about podiatry. See how important it is to stay on top of it. Congratulations. And notice that these are, we get these that come in all the time, not just pulling some from way back, hand picking ones that make us look nice. We bring you the current ones every month when we do this. So now I think we're just about ready to start the main presentation, and I'm not sure if I go first or Jennifer, so let's go see.
I didn't look at it.
And we roll the dice. Ladies and gentlemen, it is...
I know it's Jennifer because I have the answers.
You cheated.
Do you want her to read off this screen or the next screen? Which do you prefer when I pull the answer sheet over?
And when it says brackets more, because I couldn't fit it on the slide. So right here, it's the whole thing. I'd prefer she reads off this screen.
Okay.
This one, okay. So the question came in that this person is a new CPCA. So they're an apprentice. They just passed the exam and didn't have enough experience yet to drop that A category. But she's working in the billing department, which is a great place to go. She's handling all of the Florida straight Medicaid and Humana Medicaid replacement claims. So dealing specifically with Medicaid. So the question is, what is needed for an ultrasound pregnancy, no matter the trimester, but mainly that first trimester to be paid? All of our claims are being denied. We have our own machine and our own provider who can read the report, so no modifier was needed. So they're asking for some help. So this actually, I went straight to Florida Medicaid. So that's where a lot of the answers are coming from, are specifically Florida. But let me start out with some of these ultrasound codes. Now, when we look at the codes for ultrasound, we have the obstetrical and non-obstetrical codes, and obstetrical will go by the trimester. So you have ultrasound, real-time image, fetal evaluation, first trimester. So that's under the 14 weeks and 0 days. And that's for single. So that's one baby. So then they have each additional gestation. So each additional is a different code. Then you have ultrasound, real-time imaging, limited. So they're just looking for that heartbeat. They're wanting to make sure the placenta is placed properly, the baby's placed properly, or looking at the amniotic fluid. And that's one or more fetuses. So it doesn't matter because they're just doing a limited view. They're just looking for something specific. And then we have the transvaginal ultrasound real-time image. So every state has their own rules when it comes to medical assistance, and it's really easy to find. You just go to your state's medical assistance plan in the little search field. You can put provider handbook, provider manual, provider, see what comes up. There might be a tab specifically for providers. It's really easy to find, and their information is gonna be their rules. So you don't need to go anywhere else. You don't need to guess. What they say is what's going to happen. So I went to state of Florida in particular, and surprisingly, they have, I don't know how many handbooks. So there were multiple handbooks. So it took a while to find it. They have a reimbursement handbook. They have a provider handbook. They have a general handbook. They had all different handbooks. And in one handbook, they referenced another handbook. So then I had to go look up that one. So some of the information in particular for medical assistance for Florida dealing with obstetrics and ultrasounds was: the services can only be provided by that rendering provider, not a supervising provider. So these are not services by a nurse practitioner, or they call it something else in their state. I forget what they call it, advanced practitioner, I think, or a physician assistant. These are by the rendering provider. So it's not a supervisory service. So maybe that could be a denial reason there. They have ultrasound codes. They take one code per pregnancy, regardless of risks. So that's the one code that they accept as the first one. On a complex pregnancy, you can do a more in-depth ultrasound code, but it's limited to specific specialties, radiology, or a maternal fetal provider specialties. And the book actually gives the code for that specialist. So when you register with your state medical assistance plan, you're given a code for what kind of specialist you are. So this one specifically called out those specialties. Or a different code for multiple gestations, but they only do one per pregnancy. If you needed a follow-up ultrasound for specific diagnoses, and they have a diagnosis code, which is in Appendix C of the manual, you can have a maximum of up to 3 follow-up ultrasounds. So out of those 2 codes. So then if you have more than 3 are needed, say there's some kind of problem, you're going to submit additional codes in the state of Florida with a modifier 22, along with documentation. So you have to, after 3, you're sending the code with an additional modifier and your medical records. That diagnosis code is not on that Appendix C that they have listed. Then you submit with a modifier 22. If you need that abbreviated, that limited one that's just looking for the heartbeat or such, it's when it's clinically indicated. So they're looking for their medical necessity. They allow it. If you need a follow-up or a re-eval, you have to send documentation. So there's a lot of reasons here that possibly these codes are being denied. Either they're using the wrong code, it needs that modifier, it needs some kind of documentation. Only one ultrasound for the same date for the same patient. So perhaps they're going someplace else. Perhaps you did a second one somewhere. So they're only going to pay one. They call it an advanced registered nurse practitioner or a PA. They can order an ultrasound, but they can't do the ultrasounds. So that could be another reason there. If you're just hired on a new PA and they're seeing all these people in the pregnancy period, pre-pregnancy or pre-delivery period, then possibly that's could be one reason why they're getting denied. They won't allow a transvaginal ultrasound before 16 to 20 weeks gestation. So, and they only give 3 per pregnancy. So there's a lot of reasons here. That link is it's a PDF. So you can you can just search it as well, the Practitioner Services Handbook for Florida. There's many pages, like 6, 7, 8 pages about obstetrics. And they give a lot of information there. So that's where you can go to find all this stuff. Now they said Appendix C. The only problem I had with this handbook is the last update was 2012. So they're using ICD-9 codes. So whether these codes are going to exactly crosswalk to an ICD-10, I'm not sure. I don't know why their code, the other manual, the provider reimbursement manual, hasn't been updated since 2008. So 2012 is the latest update for this manual where they mentioned these obstetric ultrasound procedures. So I would definitely want to get a hold of the provider rep to see if they have an updated ICD-10 list for your pregnancy codes for ultrasounds. But that's just a short list, but as you can see why some of the reasons they're saying, of course, they're over 35, they have hyperthyroidism, they have a seizure disorder. So there's specific reasons why they will allow more ultrasounds than the 3 that they want to give. So there could be many reasons. Another thing to make sure always when you're dealing with medical assistance is that you're verifying the patient's eligibility. Are they not eligible? You need to also verify that that's the correct insurance. So do they have this, she said, straight Florida or this Humana Medicaid? Maybe under that day they were put under a different plan. So those are things always to keep in mind with medical assistance, is to always confirm the eligibility. But any medical assistance plan, any state, for no matter your specialty, family practice, obstetrics, cardiology, they should have in the handbook specific requirements. Our state of Maryland, we only allow 4 modifiers. So you don't even use a 59. So they only allow 4 modifiers and that's it. They won't even process a claim without it. So it just depends on your state, and just make sure you're double checking your provider manual for that state, and all the answers should be there.
Very good. All right. Okay, I am going to move this one. I've learned my lesson. I'm not going to get rid of it. I'm just moving it. And now we'll go to the next one. Let's see. Oh, another poll. What is your medical background? I like this one. Let me go find it here and we'll see. What is your medical background? Are you a clinician, a provider, a coder, or other? And you can put in the chat, or none. You're not in the medical field right now at all. So I think last month was the first time we had never had a provider with us. We've always usually had one provider, it seems like, at least one, and you guys are 65% done. Well, we got a lot of coders.
I've learned in Michigan that the medical business is the biggest employer here in Michigan in general.
Where I'm from in Michigan and Western Michigan, the mental health provider is the biggest business in Michigan.
That's interesting, isn't it?
6 months of winter does nobody any good.
like it, but that's just
probably-
me.
Okay, I'm gonna close it. We're at 88%, and I'm gonna share it for you. Man, that's right. 58% were coders. We have 5% clinicians. We have 2% provider. Looks like 26% is other. We'll have them right in the chat, and 16%. Good. Okay, 16%. None at all. Thank you, guys.
Thank you, providers, for making sure we didn't get a shutout there.
Not like last month. Oh, my turn. All right. So the question that came in that really, when this one came in, I was really excited. What type of questions would there be on diseases such as from mild to severe, or the location of an organ, or the description of a disease that the test taker needs to know? Well, needs to know the name of. Well, there is just, I could talk the whole hour on this, which nobody would let me do that. So I broke it down into some examples. The fact is, we code for statistical purposes, and people hear me say that all the time. I said, it just happens to be a convenient way to get paid. Thus, like Jennifer has a lot of experience on the billing end, right? But the number one reason why do we code? For statistics. We translate the information into a code set so that we can capture statistics. And everything that we are capturing is based on anatomy, the physiology, which to me I call the disease process. So you have to know the medical terminology, and that means that ultimately you have to know body systems and things like that. Everything's based on a disease. But we divide that up into, for general coding, 3 code sets. And actually, there's 4 code sets, because we have ICD-10-CM, which does our diagnoses. We have CPT, which does outpatient procedures, right? And then we have HCPCS, which is for the Medicare patients. And then we have ICD-10-PCS, that is inpatient procedures for us to capture. But everything, even the procedures, you have to know the anatomy, physiology, and medical terminology. So the question is, what are they going to test you on? A little bit of everything. Now, and we're not saying just one credential exam. Straight across the board, with every credentialing exam that you'll ever take in the medical field, for coding, you're going to have, one of any of these things that they're going to test you on. But with a CPC exam through the AAPC, 8 to 10 questions on anatomy, 8 to 10 questions on terminology. So there's almost 20 questions right there that should be just givens. You should be able to just go through those super quick, right? And that means you need to know the terminology and the prefixes and suffixes and stuff like that. So I took 3 examples that I know as an instructor with coding that have guidelines around them that I know you're going to be tested on, right? And that usually, these are probably the top 3 that I see that people struggle with. One is septic infection, or people get septicemia. There's a lot of guidelines that follow that, and the guidelines that we use as coders are not the same guidelines that is a standard of documentation or the disease process treatment that providers use. Okay, so we're not really, our standards aren't exactly the same. And then anemia. Of course, if all you have to do is go to the index in your ICD manual and see how many pages of anemia there is. So there's a lot of diversity with anemia, as well as the guidelines based on the disease process that is for coding anemia. And cancer, of course, is one of the top ones that you'll be tested on. So I just kind of divided them up. So if we take all of the body systems, you need to know all of the body systems. I'm always telling you, you need to know all the bones. Now, do you need to know all of the little bones that are carpals and metacarpals, those individual little bones? No, you don't have to know their names, but you need to know where the carpals are and where the metacarpals are and how they are different than the metatarsals and tarsals and stuff like that. You need to know the main bones. You don't have to know the names of all of the nerves, but you have to be able to distinguish what's part of the CNS and what's part of the PNS, right? Don't forget the lymphatic system and the purpose of the lymphatic system, stuff like that. So you just have to know them. Now, let's see why. Let's take septic infection. One of the things that you will be required to do is when we are working with any type of infection, whether it gets septic or not, we're probably going to have two codes. And one of the code is going to say, well, what is what's wrong with the person? They have a upper respiratory infection. Okay, well, then it's going to tell you, hey, by the way, if you know what the bacteria is that's causing the infection, you have to identify it. So there's another whole thing that you need to know. So let's say we have a staph infection, and then when something becomes septic, it divides it up into mild, all the way up to severe. And what makes it severe is the fact that we have organ failure, or we have a body system failure. Thus, we have to know the body systems, right? And so these are all things that are going to be based on knowledge that you need to know. So you need to know all the body systems. Do you need to know all the different bacteria? No, you don't need to know them. However, it would probably be a good idea before you test to just go through the list, look up infection in the index and just look at all of those terms of different types of infections and see if there's a particular one that you're not familiar with. You need to go do a little research on it, and bring up your skill set. So let's say we have a staph infection, we have respiratory failure. So now we're up to 3 to 4 codes that are going to be involved. And I just thought I'd throw this picture of Staphylococcus epidermidis because I was looking at pictures and that's what it looks like. Nasty. All right, so then we talked about anemia. And, anemia means that we have something abnormal, right? Something that's not normal. So I picked one, aplastic anemia, which aplastic anemia can be caused by something else, or it can be something in the body that's happening. Like if you have radiation because you have cancer, that can cause aplastic anemia. But we need to know the basic verbiage and terminology that surrounds anemia so that we can code properly. If we look at aplastic anemia, we have to realize that bone marrow is affected, and that means that we're not probably getting enough platelets or red blood cells or white blood cells with aplastic anemia. And then I went ahead and pulled this graphic about severe aplastic anemia because it had percentages and stuff. And I wanted to make sure you understood that we don't need to know the percentages of what makes something a severe aplastic anemia versus just mild aplastic anemia. That's not our job. Our job is to translate what the provider tells us. So if they say it's severe aplastic anemia, then we know that stuff on this list is probably involved, and we know to look for that to back it up. So we have a problem with the bone marrow. We have 3 peripheral blood criteria, so we know that we're going to see lab tests, right? And for very severe, we could have, let's see, absolute neutrophil count could be very, very low, or moderate aplastic anemia. It says patients with pancytopenia who do not fulfill the criteria of severe disease. Okay, so now we're looking at pancytopenia, and if you don't know what that is, you need to look that up, right? So that may be a term that you could see on the test. The other thing that I brought up that you're probably going to, well, I know you're going to be seeing questions on all 3 of these subjects on the CPC exam, COC, CIC, all those exams, and the CCS. So let's talk about cancer. Well, we're going to use multiple codes for cancer, most likely. So we need to know what type. A particular type of cancer is HER2 positive. And where is this particular cancer located at? It's a breast cancer. And if it's malignant, that means that it's moved. So you have to know what HER2 positive is, because you can't have HER2 positive in another type of cancer. Maybe you can have ovarian cancer that's that way, but I'm not sure. But I know it's usually breast cancer because my mother had it. So I did a lot of study. So what ultimately happens is we have this HER2 cells, and it is a estrogen cell that this particular type of cancer uses like as for a train for movement. So the more of those cells, if you have an abnormal amount of HER2 positive cells, that means these cancer cells, ride them to other places in the body. And that's a more, I don't want to say it's a more severe type of cancer, but it's more problematic, right? Because we have a higher chance of malignancy with HER2 positive. Thus, if that's the type you had, and there is estrogen positive, you'll see that in a lot of these codes, was it estrogen positive, then we know that those people will be given medication to suppress estrogen in the body. And that's it. That's kind of an overview of things that you need to think about when you go to consider what type of questions that you'll see on the exams. Again, I could talk about that all day long. So, all right. Let's see what's next. Is it another poll, maybe? No. Hey, just going to take a minute to tell you about the CCO Club Prime. I mentioned it earlier. It's something new that we launched. You can go to cco.us/club to get more information. Ultimately, we changed the way we were providing our courses for not the way we provide them, but the way you pay for them. We had a payment plan. Not everybody has payment plans out there, but then Laureen was really anxious for us to get to a point where we could give you the best value that we possibly could. And so we came up with CCO Club Prime. So you pay a flat fee, and I think it's $4.99, a one-time fee. And then you pay a monthly fee, which is it's going up. So I think will end up being like $49 a month for your classes. And then once you can pick any class you want, once you finish that course, and that means you've passed every chapter or module, and then you can pick another one. And we have so many courses that you can choose from the billing, risk adjustment, the CPC, the COC, the facility coding, inpatient coding, compliance, pharmacology. Help me out. What am I missing?
Auditing, practice management.
Yep. I just did that auditing one. So you could, whether you take the credential of not, like compliance, it's in everything, right? And so there is an aspect of that in all of the credentialing exams, or medical terminology and anatomy. We have a course in that. Maybe you want to take that, and maybe you just need a refresher. But the key is that you get to keep the course that you've completed, and then we update it, right? So every year, all the updates are applied. And then by the end of, a year or so, or however quickly you go through the courses, you could end up having every course that we ever offer, for that low monthly fee, right? So anyway, go look at the cco.us/club. We've already got people that have in the testimony that have said that they are passing with that. So that's really good to know. Okay, and there you go. I'll take my picture off real quick so that.
So we had a question come in about having a Medicare edit issue with multiple procedures on one claim for a series encounter that spans multiple dates of service. So this is for a critical access hospital. So there's a little bit more on the answer sheet that we have. So they were having a problem because the CPT codes are, I'm sorry, the codes are in the surgical range that they're having problems with, and they're hitting NCCI edits in their direct data entry that they do. They have a WPS Medicare. So saying that those should be rolled into one. And they've never had to do this in the past because each procedure is on a different data service. So the Medicare MAC should just be able to tell that there are different procedures because they're on different dates of services. They've contacted their MAC carrier and they've gone to high-level supervisors who say everything's fine. So they're just kind of looking for any more insight that we might have. Now, I've never billed critical access hospital, so this took a lot of research to figure out. I do mainly everything outpatient. Now, critical access hospital is a rural hospital that has to be more than 35 miles from another hospital. So you're talking a rural area. They're small. They have 25 or less acute inpatient beds. So it's a small facility we're talking about. Typical stay is usually 96 hours or less. They'll either discharge them or they're going to transfer them on to another facility. They can stay longer than that. Medicare has restrictions for the or criteria for them to stay longer than that that need to be met. But otherwise, it's just something to have available in a rural area for when there's a problem. So there's two ways that a critical access hospital can bill. They have method one, where the professional medical services, like a doctor coming in to see the patient, the professional services of providers coming in are furnished on the CMS 1500, go to Part B, and the facility goes to Part A. That's usually a standard format for our services. So you have a provider who comes in, a neurologist, a cardiologist, something like that. They have an outside office that they usually work in. They're coming in to see this patient and take a look at him. They're going to bill their professional services on a CMS 1500, and the whole time the patient's in the hospital, all those services are going to go on a Part A, or to Part A on a UB04 form. Well, there's method two, where the critical access hospital bills Part A for both facility and professional services. So everything is being rolled into one. So each service has revenue codes that go with CCI and medically unlikely edits. Those guidelines, they're still followed, and the same surgical rules apply. So your global periods are also going to apply, even though you're billing kind of this all thing together, Part A, everything together. The professional then, they've signed over to the hospital that they are not going to bill these services. Their money is going to go to the hospital, and then they would get paid that way. So the only notations I can find that could help with this concern is there is a pre-admission bundling requirement that if the patient is admitted on the same day or within 3 days of any outpatient service, they require separate claims. So possibly something was bumping up there. There's also a repetitive billing feature. So if some of these services say were physical therapy or chemotherapy, radiology, some kind of repetitive thing that they're going to do each day, then they were asking for them to all be billed on one line with your from and to date, or to and from. So you've got, 4 days on there, however many, January 1st to January 5th, with your physical therapy services. So this note didn't say what kind of services these were. They just said CPT surgical. Well, I understand they're running up against edits. So they say that the global period still applies, though. So if we're looking at providers seeing a patient, and this was treated like an outpatient hospital, that's another rule that it says when you're looking up Medicare's rules regarding critical access hospitals, that you might have another doctor coming in to take a look at them on that same day, perhaps, that another service, well, they're going to apply those global service rules. So even though it's not the same doctor, if they've signed over all their benefits to the hospital, then they could be bumping up against tax ID issues. It could require items all to be on one line. There was no definitive. I went to WPS. They did say that there was a problem with some payments of CAH payments back in January. So I'm not sure, how far back the question was having problems from. They did have problem processing payments, but that was dealing with nurse anesthetists. So they were processing claims improperly. So perhaps this is relation to a nurse anesthetist. I'm not sure. Typically, you'd want to then, if this is the case and you've talked to supervisors and they're saying everything's correct, you're going to want to see what that denial is going to be, what that exact reasoning is as to why they want this information. And then you need to try and have somebody find it in writing for you. Perhaps there's some LCD that came out for that service or something that you need to go straight to that and find, get that exact rule. It's possible that when some update was done at the beginning of the year, that accidentally a button was pushed. And so they're saying, well, yeah, the supervisors are looking at going, well, it shouldn't do that, but somehow it is. So whether the direct data entry had some update, possibly, that's something that you may want to get your provider rep to look into. So unfortunately, I didn't have an exact answer to this question, but there are other options out there to look at, whether contacting your provider rep and see if perhaps an update was done. I've seen that done before, that updates were done and a little checkbox was put somewhere and it was kicking out claims. And it took a while for them to find it. It took a while of phone calls, but it took our provider rep to actually look at it and figure out exactly what was going on with that. So there are certain areas, perhaps it's a repetitive service and they were looking for them to be all put on one line. So even though the CCI edits say you can do these all, they were asking for them to be on one line. So there's a couple different things to look at, but unfortunately I didn't have an exact answer for their question. So
That's still really good stuff. Oh, let's see. Hold on. I'll get this moved over. Yep. Okay. Sometimes too, when we do these, it's true. We almost need more information to find out exactly.
They gave a lot of information, knowing that it's a WPS and still, but
That's
still you're
good.
kind of like, what exactly did you need? Yeah.
We're ready for another poll. Which area do you feel you need more education in? This one really helps us. No, oh shoot, I just launched the wrong poll. Okay, I launched the poll that says, are you currently employed in the medical field? Or I think it says yes, no, but looking for work. No, not pursuing employment. So I'll launch the other one. Sorry, so the screen that you're seeing is wrong, but you can read the poll, of course. And let's see, here we go. We're at, a little slower now. We're only at 50%. Okay, so I'm going to count it down. 5, 4, 3, 2, 1. Hurry, hurry. Oh, now everybody's starting to do it. Okay, and close. So it looks like, are you currently employed? 64% of you said yes. 20% said no, but looking for work, and 16% nope, not pursuing employment at this time. Maybe because you are a student, right? That'd be an excellent reason why you wouldn't be. Okay, well, we'll get this question of where, what other education do you need next time. This is mine. This was, can you go over how to code for a TAVR procedure, or the Watchman as it's sometimes called? So I did look into this. Oh, hold on just a second. I thought I grabbed the wrong one. This was a lot of fun to do research on. because I had been familiar with this procedure, but things have changed since I've done this. And so I really narrowed down on Watchman, actually, because it's actually not a TAVR. They're a little bit different. So for the most part, if you are going to have a patient that has aortic stenosis and severe aortic stenosis where they need to do something, they've got a low surgical risk for open heart surgery, and they do a transcatheter aortic valve replacement. That's what a TAVR is, and sometimes they call it a TAVI, which is a less invasive procedure. What they do is they go in and do, there's 3 approaches here that I found. One, they'll go up through the femoral artery, you can see here, and then they do their procedure in the valve right there. This one is a apical, or, they go up under the arm, or actually it goes in the chest, but that's one approach. And then the other one is the transaortic, where they go in there in the front of the chest. Okay, so these are TAVRs. Trans aortic valve replacement is the procedure. So you can imagine that there's going to be a lot of different things that can be done, and reasons why a patient would have this done. There's more than one reason to have a stenosis in a valve. Now, the Watchman device is a little bit different, though. It's not a valve replacement. Ultimately, people that have arterial fib or AFib, and if the condition that they have is this extra little appendage off the heart, it's called a left anterior, excuse me, I'm saying that wrong, a left arterial appendage, then they've got to block that off, because if they don't, that can pool blood and then you can form a clot. So again, you have to have 2 things for this Watchman. You have to have AFib, and you have to have an LAA, which is that left arterial appendage. Now, let me show you what they do for it. They go in and they do this Watchman LAAC procedure, and I've got a picture of it here. But not all payers pay for this. The code that you're going to use if you're doing PCS, because for the most part, this is probably an inpatient procedure that's done, is going to be O2L73DK. What do we have going on? We have an occlusion of a left arterial appendage. So again, you have to have that little pocket up there by the atrium on the left side with intraluminal device percutaneous approach. Now, it's not just about the PCS code, though. You have to make sure that you have medical decision making, right? MDM. You have to have, it has to be a necessity. And again, Medicare doesn't pay for this particular device. So CMS billing instructions, what do they tell you to do? First of all, for a hospital claim, they have the following things: the NCD for percutaneous LAAC procedure, that's what we're doing, the Watchman. This was all done at 2016. The fact is this Watchman device, which I'm going to show you a picture of here in just a minute, was relatively a new device, and it had to go through trials and stuff like that. But they are not going to pay for it, and then unless you have the proper ICD codes to back it up. And they're saying one of the following: you've got to either have proximal AFib, persistent AFib, chronic AFib, or unspecified AFib, and then there's your codes. Now notice there's probably more characters that you have to do. And then a secondary diagnosis code of Z00.6 would be applicable. Also, it is only for inpatient. Medicare will not pay for this outpatient at all. Doesn't mean that you can't do it, but Medicare is not going to pay for it. Payer specific otherwise is what you need to know. This is what this Watchman looks like. Now, if you're going to do outpatient PCS, or not PCS, it's going to be 33340, which is the transcatheter closure percutaneous of the left atrial appendage. And this is what this looks like. So see this little pocket? Not everybody has this. You know, this is an unusual thing. This is about the size of a quarter, and they go in and place that and then give it a little tug because it's got little barbs on it. And then it's got this filter so that if blood gets pushed through there, clots can't come back and produce clots. So this is where you're going to see that appendage sticking out, right? And this is where this is not a normal thing to have. And that's where they're going to put the Watchman device. This is the catheter that goes up and places it. So they stick it in there and then they pull it back to make sure it grabs with the little barbs. This is, let's see, the site of the clot that can occur. See how they've got that appendage and how a clot develops right there? Anyway, I thought that was pretty fascinating. So things you need to know about coding. If you're going to use CPT, outpatient, Medicare is not going to pay for it. It's going to be 33340 is your code. If you're going to do inpatient, Medicare will pay, but you got to make sure that you have AFib or they're not going to do it. And just because the person has this appendage, I wasn't able to find if that automatically means that you have AFib. But for PCS, you're going to be looking at O2L73DK as your PCS code. It's all about the root operation. And this is going to be an occlusion. That's what we're actually doing. We're occluding off that little pocket. There you go. So I really kind of went with the Watchman because the other procedures have been around for a while. The Watchman is pretty new. And now we're ready for the next one. Are you currently employed? Well, now we can go back and do that other. Let me just grab the other one then, says, which was, which area do you feel you need education in? So it's going to say, do you need it in billing, CPT, ICD, specialty credentials? Let us know which one in the chat, or other, and you can write in the chat or the question. Yay. Oh, Whitney wants to know, could we do a monthly webinar on cardiovascular? Sure, we could.
Oh, cardio. Yeah, I should get my friend, right?
That's right. We've had a lot of things come in.
Yeah.
And as you guys are voting, it's funny because you know, I know you guys like to think we know everything, but we don't. We don't.
Oh, come on.
Yeah, but the great thing is that we surround ourselves with other people that know, that are in the know, you know. And Jennifer has a great connection, a SME for cardiology. And so that's really cool. Looks like we've got rheumatology, risk adjustment, anything to do with integumentary and spinal fusion. Oh, well, now, see, Jennifer works for an orthopedist. So, okay, we're at 70%. I'm going to get ready to close, guys. 5, 4, 3. They're still coming in. 2, 1, go. Oh, wow. CPT wins. CPT, did I hit share?
No.
Okay, 18% billing, 48% CPT, 22% ICD, which is my favorite, 8% of the specialty, and so that's where we got the cardiology, rheumatology, interpreting and understanding op reports. Hey, that's a good one, Kathleen. I like that. That's a good one. We do those on the case study when we do those. All right, I'm going to hide this poll. And we're back. Let's see who gets to go next. Jennifer, of course.
I'd say it's to me.
Yeah.
That's an
right.
old question.
Is that not the right
That's
one on
old.
the thing?
No. You can probably go to the answer sheet. That should have the right.
Okay. Okay. Got it.
See, I think I did that one last time.
Yep.
So, yeah.
Yeah, we did. Okay.
So this person has a job in billing and they're a little bit nervous because those denials, that means money coming in. So that's a little bit nerve-wracking, making sure you get that money. So when it comes in, what are the steps to fixing that claim? How do we get that claim gone? So the denials come, it could be a simple thing, it could be complex. So it all depends. It's going to depend on the denial. So it could say one line item is denied as inclusive, and you look at it, well, it's missing the modifier. Oops, somebody missed a modifier. They could just be requesting other health information, or a primary EOB, an accident detail form. Those could be classified as denials, even though they're not processing the claim yet because they're requesting other information. So denial is kind of a loose term that we use. Anything that's not paid is pretty much denied, but there's suspended claims, there's pending claims, they're not all denied. Or you could have that ever important medical necessity, or even that missing authorization. So it depends on the reason for the denial. So a claim that's denied missing that modifier, that's a corrective claim, a correction, not an appeal. Some people might call it a reconsideration. It depends on the insurance company. So there's actually, this is an example of United Healthcare. I just cut and paste the top and the bottom of their paper claim form. So if you're going to send a claim in via paper to United Healthcare, they have a form that's required. And a lot of the insurance carriers actually have a form that they want you to send along with it. Because what happens if you don't send this form? You're sending a paper claim. Well, they're going to get it. They're going to process it, but you've already sent in that claim, so they're going to deny it's a duplicate. So this form is drawing their attention to, hey, something's been changed. So on this form, they say, make sure you put the claim number on there, make sure you include this information, and then they have little check boxes to send in, say, oh, I corrected the claim, something else needs to be done here. You denied it as exceeded timely filing. Here's my proof that we didn't exceed the timely filing. Say they have a second insurance company and we sent it there first, or you've got the other AOB paid. So they also allow online corrections with United Healthcare. So you could just, for certain reasons, some of simple ones, just please reprocess this claim for this reason. I adjusted a diagnosis, I added a modifier, things like that, just send it online. Actually, something small like that are local medical assistants. They've told me you can send the claim 100 times a day if you want. They'll keep reprocessing it. So when we get it there the right way, then it's going to process and pay. But they will just keep reprocessing the claim. They don't deny it as a duplicate. So it just depends on the carrier whether you could possibly just resubmit the claim with the new information electronically. They might process it. Medicare is one of those. It depends on the denial code that they gave. A claim that's been pended or suspended, we call it denied, but they're actually waiting for more information. So it's pending further information. Medicare sometimes calls these a suspended claim. They're waiting for additional information. They'll process it, but they need to get that information first before they're going to process it. So typically that's for coordination of benefits. They may say the patient has another health insurance plan and you need to go through them first. They may have conflicting information, or they need additional information. We encounter this all the time in orthopedics. People fall and injure themselves. So they want to make sure that it's not in relation to possibly a workers' comp, a liability, automobile, somebody else who could maybe pay that claim before they're going to pay it. So they're pending accident detail information. And those are things that the carrier is saying that patient's responsible for this bill for you until we get that information. So if we don't get that information, the patient owes you that money because they're not fulfilling their obligation with the insurance carrier. So you would then put the claim to the patient responsibility, make phone calls to the patient. They're getting their statements. Hopefully they'll get this. The phone call is usually nice in an instance like this because when the insurance company sends something to the patient, it usually comes in an envelope looking like junk mail. And most people just throw it away and they don't even look at it. So it's good to call them and say, hey, your insurance is requesting information from you. And also sometimes you're not the only doctor that's claim is being held up. They could have 4 other doctor's offices or a hospital visit perhaps, or something that their claim's not going to be paid. So they need to get on top of this. If something's denied for medical necessity or perhaps an authorization, I forgot to put authorization in here, so let me run through that one real quick. Most insurance carriers' websites will indicate, or calling an automated system, they're going to indicate a procedure or a visit may require an authorization. What if we're not all knowing and our doctors are not all knowing? We're going to take this patient to the hospital for their surgery. We get in there and, oh, that's not what I thought was going on with the patient. I need to do a different surgery. So that happens sometimes, that we think it's going to be this CPT code, and then we get in there and say, nope, or we need to add more procedures to it. So one of those may require authorization and we didn't obtain it. So typically that's a big process. That could be a peer-to-peer, or that could be submitting additional information like the medical records and finding out what's wrong with the claim. But now a medical necessity, a lot of insurances have a particular way they want that done. So they may want step 1 done first, and then you go to level 2. So there's certain ways that you want to check on their website and make sure what their steps are. Aetna has another form. This is an appeal request form. So I'm requesting an appeal. You're going to put in all the claim information. You're going to put in the procedure codes and the diagnoses, and then tell them why you want this appealed. So denials come, these codes that we're looking at on explanation of benefits. There's remittance remark codes that are telling us something's wrong with the claim. There's a link. There's actually all printed on a website, and every insurance carrier follows the exact same ones. They all list the exact same ones. So it doesn't matter whether you're dealing with a small insurance carrier or Medicare or Blue Cross, they all follow the same. So like an M20 is going to come, and that means a missing or incomplete or invalid HCPCS code. So maybe you sent one from 2018 and you didn't, it got deleted in 2019. So it could be missing, could be invalid. So some of those are going to give you a hint as to what your denial is. Now say it was that. Say we had an invalid HCPCS code. Well, it was deleted last year. There's a new code this year. So I need to adjust my information and send in that new HCPCS code. So does that mean send a whole new claim? Well, if that's the only thing on the claim, then yes, send the whole new claim all over again. But if it's part of several lines of procedures, then you're going to want to send in whatever they need for a corrected claim. There's also claim adjustment reason codes are something else you're going to see on an explanation of benefits. Some of these are very familiar, like you have your PR1 deductible, patient responsibility PR. PR1 is their deductible, PR2 co-insurance. 3, we've seen these before, those are standard, those are your patient responsibility. But then we get some weirder ones that are out there, and you wouldn't think that these are codes coming back on a claim, but some other denial codes could be patient was out of the country. They're listed down a little bit more, Alicia. So patient was out of the country, or service was out of this country. They refused the service. This service was provided as a result of an act of war. Well, who's going to pay for that? And so some different things that you don't see every day, but there's a code for every one of these, just like there's a CPT code for an ICD-10 code for anything you can think of. There's denial codes as well. So what are our steps? You're going to want to verify that that information is correct. If they denied it saying they can't identify the patient, well, let's go back and look at the copy of that insurance card. Make sure we didn't transpose any numbers or letters. Make sure it's the current card. Some people carry their cards around for 10 years in their wallet and didn't realize they got a new one. So making sure all the information is correct. If you adjusted on the claim and it was a patient information, adjust it in the patient file so that you don't keep getting that denial every time it comes back. Look at the carrier's website or their provider handbook to see if they have instructions for how to do a reconsideration or appeal. Most of them have a form and they'll tell you where to send it to, which address. Some of them divide it up between the countries. So if you're in one half of the country or in a certain state, you're going to send it to this address, where somebody else on the other side of the country is going to send it to a different address. So it just depends. But also make sure that there's no guidelines for that CPT code. That's probably the one thing you don't want to do, is spend all this time writing an appeal, pulling information from societies, having your provider write a letter, making phone calls, only to find out that the insurance company says in order for a patient to have this service, they must meet A, B, and C. If you only did A and B and you didn't do C, the insurance company is not going to pay for it, no matter what. That's their guideline. That's their rule. And if we don't follow their rules, then we just spend all this time doing nothing. So always double check that too. Make sure that there's no guideline about that. Make a copy of everything that you're sending in. You don't need to copy your medical records because those should be in your electronic health system, but the form you send in, the HCPCS, the CMS claim form, any supporting documentation you send in, make a copy of all that. Indicate the date that you sent it. Send it all in. Follow up, keep them in a folder, perhaps one of those that has months or perhaps days, and put it 3 weeks out and go, okay, on the 21st, today's the 1st, on the 21st, I'm going to check on this and see the status of it. Or I'll put it behind May, and come May, I'm going to call on all these. So definitely have a good system to keep up with your denials. But if we follow that up, generally in 30 days, 45, possibly some carriers are a little bit slower when it comes to appeals. But if it hasn't been processed, you didn't get your money back yet, contact the carrier. Make notes of the name, the phone number you called, because sometimes you might get transferred, or they might say, oh, you need to call this number for that. So the date and the time, of course, keep track of all of that information. If they say they didn't receive it, can I email it to you? What's your fax number? Can I fax it to you? A lot of those representatives that we speak with, their fax numbers are nowadays like they go straight to their emails. It's a desktop fax, or I'm not sure exactly what they call it, but they get it immediately to their system and it's in their inbox to check. So some of that's helpful as well. And then follow up again. This time we're going to go quicker, because if we send it again, and we need to stay on top of these things. A lot of insurance carriers have filing limits, even for appeals. Medicare could be 120 days. So we need to stay on top of these and be timely and keep harassing them till they either pay it or deny it. If they have a flat out denial and you've gone to your second level, then you might want to discuss with your provider, look, they're just not paying this. We talked to them, you sent in that letter, they're not paying this service. It's not going to be covered. And then it's a write-off, because it's not the patient responsibility unless it's one of those coordination of benefits or accident forms that they're requesting. But otherwise, under medical necessity, they don't make it patient responsibility. So
More good stuff.
diligence is always the big key word.
Diligent, right?
Yeah.
Okay, let's see. I don't think we have another poll. I think it might be nope, we're gonna we do surveys. So if you want to help us out by doing a survey, you can go to cco.pe/QA201904, and that would help us out quite a bit. Keep us on our toes and make sure that we're giving you the content that you need. All right, now for our this is our last one, I believe. the question came in, can you explain the difference between tunneled and versus non-tunneled and centrally inserted versus peripherally inserted portacaths? Well, I sure can. So I went ahead and uh, divided it up into central venous catheters. Okay, so that's what we're really talking about. And the question ends up being, what's the difference between tunneled and non-tunneled? Ultimately, when and the key words you're looking for is how long will the person have the cath? Okay, so a cath is anything that is put into the body to let things in or let things out, right? It doesn't have to be in a vessel because we have urinary catheters, right? But for the most part, we're talking about venous catheters here. Tunneled catheters are intended to stay for longer periods of time. They go under the skin and they have a separate exit point. That's how you know it's tunneled. They can have more than one lumen. Now, when you talk about a lumen just means that it's a tube. So we have lumens in our body. It's just a tube aspect of the anatomy. But I've got some pictures here for you to see. And the lumen that they're talking about is going to have probably, if it has two, it'll have like two little plastic apparatuses that come out, and then you can inject things into them separately. So common names, some of the top tunneled venous catheters are going to be a Hickman. This is, they will look for Hickman, but there's called a power Hickman. And then there's a multi-lumen Hickman. Also, you could have seen called a Broviac long-term dialysis catheter, a Groshong, and I used to call it a Groshang, but it's called a Groshong, and I may not even be pronouncing it right but to me, I was called it a Groshang, and everybody just rolled their eyes at me when I was in the hospital. Then there's another one called a Neostar, and I don't know that one as well. But usually it was a Hickman or a Groshang that went in. Now, there's other types of tunneled ports. Now, these are ports that are implanted, and for the most part, it's usually somebody that has more of a chronic or long-term illness that's going to be treated. Definitely, if you're going to be getting chemotherapy because of cancer or something like that, they'll put a port in because you're going to be going in frequently to have blood draws done, and they need to get medicine in you, and this actually makes it more stable for a vein. So this is a port that goes under the skin, again, long-term therapy, and it can also have one or more lumens, those little tubes that come that you would use, but for the most part, you see them with one. The big ones are called power port, titanium dome port, and there's a slim port that is also used. Now let's look at a picture of those. I think, oh no, must have it down at the bottom. You know what? I don't think I added the pictures because they were copywritten. That's what it was. I don't think I did. So what you need to do is go out and Google image central venous catheters. Yeah, so I was looking at all these, I'm like, and I couldn't find one that I could get permission to use. Another type is a dialysis catheter. This is going to be tunneled. It's going to go usually into the superior vena cava. They can do an arterial venous fistula a lot of the times that are used, and these are called a hemosplit, and these are long-term dialysis catheters because, again, people that are doing dialysis are doing at least 2 times a week. Right now, non-tunneled, these are short-term. Usually with non-tunneled, you're going to see them done a lot of times in the ER. The one that I saw done that, wow, it was impressive to watch them do. It was a really difficult job, but we had a woman in the ER that had a motor vehicle accident. She rolled her car. She didn't have her safety belt on, and quite honestly broke almost every bone the doctor said. But so her arms, which would normally look at the length of your arm, and her arms were just down to her elbow because she had like shattered her both of her arms, and so it has shortened the arm. So they were wanting to put in a cath, and they had to do a cut down and get into the subclavian artery, and they had an awful time trying to get that done. But it's non-tunneled, short term. They just had to stabilize her enough so they could get her on the helicopter and take her out to the university because of the condition that she was in. One of these is, there's all kinds of names for them, but the resources I was using, this elite dialysis catheter called, and I think this is called I'm not probably going to say this right, Maherkar. I don't know where to put the emphasis on it, but that's a type of temporary dialysis catheter that's done. They can do the subclavian, like I got to see, which was a central venous catheter, and it had like, a dozen, well, it wasn't a dozen, but they had, like 4 or 5 ports or lumens sticking off of it, and they were all color coded. So because they were going to have to put in multiple IV bags and so on and so forth. So these would be central venous catheters. You might see them abbreviated as a CVAD. And then the types that you're going to see on these non-tunneled, of course, we've got the documentation, especially in the nurse's notes. You're going to see single lumen, which would be an SL. You might have a double lumen, so that have 2 appendages off of it, DL, and then a triple lumen, which would be TL. So again, it would say like, you would see documentation that said CVC SL. Right, then you knew it was a single lumen central venous catheter that was put in. And again, these are temporary, unlike tunneled, which are meant to be long term, especially with the type, if you're going to be having chemo, you'll wear those for years. And I think 12 years was the limit on those. And sometimes they don't want you to take them out because if you have a reoccurrence of your catheter, they have to go in and do them again. And they're put in surgically, not just, like this one, non-tunneled are usually done in the ER type atmosphere. It's done quickly with just, general anesthesia, whereas the others, more anesthesia. There's also a quadruple lumen, but I didn't have an abbreviation with that one. So some other documentation that you're going to see when dealing with these types of caths, with non-tunneled caths, okay, they are temporary, and it doesn't matter if it's a multi-lumen percutaneous or not, but this documentation is going to give you a heads up that we've got tunneled versus non-tunneled, stuff like that. So they have to be flushed. We have to use heparin to keep these caths open. If you ever get medication via an IV, if you've ever noticed, the nurse will go in and give you an injection, and it's heparin, and then they'll a lot of times then they'll give you whatever medication they're supposed to give you, and sometimes they'll flush it afterwards again with heparin. But they'll come in and they'll say, I'm going to clean out your IV, and they'll give you that flush of heparin, and ultimately heparin is just a blood thinner, so you don't clog up your IV. And the documentation, you really don't necessarily need to know the difference between how much heparin a person gets if they're an adult or a toddler or stuff, but I went ahead and added that. So if we do a heparin flush, then we know that they're going to give them heparin every 24 hours, okay? And also that for intermittent use, then there's like just going in and drawing blood, because if you have one of these in, they can pull the blood directly from those, depending on what they've got plugged into you. Then again, pediatric and toddlers and neonates all have a different flush time, but this is the documentation that you're going to be looking for when you're determining something is tunneled and non-tunneled. So you noticed every 24 hours they're flushing, whereas if you have a port, a tunneled, it's not going to get that that flush is often. Now, before they you go in and have your chemo, for example, they may give you some type of a flush, but it's not for it's not an every 24 hours thing, right? Because you may only go in every 3 weeks, once every 3 weeks to have your treatment. But even after you are done with your treatment and say they're not going to take out that tunneled port, then again, you still have to go in every so often and have that flushed and cleaned out, because we're in the vascular system. So that's the difference between the tunneled and the non-tunneled, and when it's centrally inserted versus peripherally inserted. And peripherally meaning we're looking at more things like IV catheters, not something that is put inside the vascular system. It's good stuff. Documentation really goes a long way. And this is another reason why clinicians make such excellent coders, is because they know all of this stuff, right? They know what's going on behind the scenes. Okay, let's see. We are ready now to talk about the CCO Club. For the most part, we have finished up the main content of the webinar, so we're going to just go over a few things and get ready for our drawing. The CCO Club, we told you about the CCO Club Prime, where we offer courses, but say you don't need a course, but you want to get CEUs and you want to be able to have continued access to webinars. We do, like 5-6 webinars a week, and maybe you want to attend those live, or you, if we air them, live stream them on YouTube or Facebook, we pull those out, right? We don't keep them up, but you want to come back and be able to look at them again. Maybe you want to have priority when you ask questions and support. You can join the CCO Club for a real minimal fee, and all you have to do is go to cco.us/club and then get more information. Of course, Prime allows you to take courses, and it's a really affordable way to do that. And we've already gone over this a little bit. We are I told you I wasn't sure about the price, but $4.99 for the initial payment, and then $39.99 every 30 days. And then again, we have a list of what the benefits that come with that. And it's just that one-time initial fee. So this makes a great option instead of a payment plan. But these prices will be eventually going up, so stay tuned to cco.us/club to pay attention to that. Are we ready for a drawing? I know that Boyd's probably working in the background getting that all set up for us. You can have a Blitz video package. You can have a 1 year of our CCO Club Basic that we were just talking about, where you get all that priority with us and access, or you can have an hour session with me to talk about questions, and maybe Jennifer too, but I don't know why her name's not on here. But anyway, or you could just get the 1 year CCO Club, and then I'm at your fingertips.
Ask
anyway.
as many questions as you want.
Right, not just one. But, Boyd, did you come up with a person?
Yes, in our random drawing, we have Coquette Bonner is our winner, who's attending here today.
Woohoo! I saw her name come up.
She's
Yay.
made several comments. Yeah.
Yeah, you
Awesome.
lucky person. Yeah, one of the advantages, we didn't have as many people on tonight, so that was lucky.
Yeah.
Very good. Okay, so what you need to do, Ms. Bonner, you just send a message into helpdesk@cco.us, and I know Sylvia and Lori are in the background, and they will look for you to do that, and you can tell us which one of these you want. Everybody's saying congratulations to you.
Hey.
All right. Just a reminder, CEU certificate is not going to be ready for a few weeks, but when you're a CCO Club member, you'll be able to access that, and we give you heads up and everything. That's why it's the perks to being in the CCO Club. So if you choose to do that. Now, we're going to go and look at our questions that have been coming up. Sylvia and Lori have been adding them to our other So now I gotta go find it. Let's see, what did I do with it? I had it up, I thought.
You have to refresh it or anything,
Maybe I do. Let me refresh.
or just click the blue link on there. It'll come up again.
It will? Okay,
Yeah.
let's do that.
It might take a
Oh,
while.
there it is. No, there it is. It's right. It's right here. I already had it up.
Yeah, you probably have to refresh it.
It was behind the in the
It
back.
looks like there's been some writing.
Okay.
Yep.
I'm going to pull, when that refreshes, I'm going to pull that down so that we can get a better view of it. And that way I can see. Just
Sounds
give it a
good.
second to refresh.
So these are the questions that have come from you, this audience here tonight. Those of you who were smart enough to say, gosh, doesn't something happen at 8 o'clock normally? And we apologize again to everyone who came in at 9 o'clock because we started at 8 o'clock, our normal time. And my little princess has come to join us in her 4-year-old awesomeness, which is why I lost my camera. Anyway, so questions in the chat, April 2019, go for it.
Okay, it's still loading. I'm sorry. Where's that?
Hey, Alicia, are we going to do any lives next week?
Yes, we have a bunch of lives coming up. Well, of course, we got Easter, guys. So
From HealthCon.
There
and
was a question about CCO Lives. We normally do them on Wednesdays from now on. Is that correct?
yes, we do.
Yeah,
And,
so the only reason that we didn't do one yesterday was because we have a webinar today, so we don't try to do stuff in the evenings back to back.
And just so you know, that Jennifer and I are both going to HealthCon. So the end of the month, we will be flying out. I think the 26th, we're flying out. We'll be there till what, the 2nd or 3rd of May. And we'll do a lot of Facebook Lives. So stay tuned to if you're not already clicked into our Facebook, make sure that you do that so that you can see Jennifer and I going around and meeting lots of
Gambling.
people. I'm never going. I guess I could.
No, $25 is my max. So
I've never done it, so maybe I need to. Okay, the question is there a difference in billing and coding for, I don't know what that means.
The locum
Provider.
I'm on
Okay,
top of it.
I thought that means my eyes. Who stays in an organization for a week compared to a locum that is there for 2 months. Can you discuss the Q6 modifier and any tips to make the billing and coding locums not as confusing? Okay, Jennifer.
You want me to go?
Yeah, because I ain't got a clue. I guess you guys don't know, but maybe I've said it before. I don't particularly like billing them.
I like billing.
I only had to do it for like a year, and I was like, it was great. Glad to get out there.
Well, this is, of course, in the Medicare manual. So if you ever need to know something, just look there first. So locums, they don't call it locums anymore. It's called fee for time now, but most people still refer to it as locums. Locums is when your provider is either out on maternity leave, doing some kind of sabbatical, research, anything where they're going to be out and they need somebody to take their place. So another provider who doesn't have a practice, they just kind of travel around or do, maybe they used to be in practice and now they just help people out. So it's usually somebody who doesn't have their own practice is going to come in temporarily while a provider is out so that there's a continuity of care still with their patients and they don't have to have other people in the office try and get the burden for somebody who's out long. You think of maternity leave, they're going to be out at least 6 weeks. So you have some time there that you don't want those patients to not be seen. So a locum will come in and see them. Now the difference is they now call this fee for time. So think of it that way. The provider who is out, so you have a provider on maternity leave, that provider is paying that doctor to come in and see patients. So you're not billing your claim under Dr. B. you're doing pregnant doctor A. So pregnant doctor is going to be on the name of all your claims. So that's why we include the Q6 modifier. So that way Medicare or any other provider knows that this person who's on this claim form hired somebody to come in and see their patients because they happen to be out. So these are not incident 2. These are normal physician services, so they can see a Medicare patient and diagnose them for the very first time. They don't have to work under a supervisory provider. Now, there is a restriction of 60 days. So in Whitney's, in this question, there's no difference between a week or 2 months. You're still doing the same thing. It's for a length of time that the provider isn't there. There is a 60-day limit. The only way they waive that limit is if that doctor is fulfilling their services with the armed forces. So they are called up to duty or something like that, and it's going to go longer than 60 days. That's the only case that they allow a fee-for-service provider or locums to go longer than 60 days. So you can have a provider come into your office up to 60 days. You still bill under the name of your own doctor with a Q6 modifier on there.
That's really cool. I did not know any of that.
Oh, and it's for physical therapy too. So not just
Ooh.
doctors, but also physical therapy. So, yep. Yep.
Does it work for nurse practitioners and PAs or no?
Well, no, because they bill typically incident 2. Under
okay.
Medicare rules, they're billing incident 2. So this is mainly coming from Medicare.
Okay,
So,
good. All right, this one, I saw this one out of the corner of my eye. I code for wound care clinic. I sometimes have problems finding a diagnosis code for the office visit when debridement is done. Any suggestions?
that's Alicia.
Yeah, I can
That's
tell you.
yours.
And you know what? Talking about PT, this is something that they have trouble too. It's the diagnosis code, because we are so driven in the outpatient world, if that's what your background is and everything, that it's all about the CPT code, right? Because that's what you're being reimbursed on. And we forget that the ICD code is the reason for the CPT code. So whenever you have any type of, they're really not ancillary clinics, let's call them specialty clinics. So whether a person's getting PT or they're going to a wound care clinic, maybe they're going to a special diabetic foot clinic where they go in and have their nails done and things like these. So these are ancillary specialties that work along with another provider. There's still providers there, but they're taking the documentation from, say, the general practitioner, and then they're saying, okay, I want you to go to the wound care clinic because this is their specialty, and they're going to be following up with this diabetic ulcer that you have on your toe, or this spider bite that isn't getting any better, and then they may put like a wound vac or something like that, or hyperbaric treatment, or just do debridements because it's what their specialty. And just so you know too, PT, some physical therapists are wound care specialists. We don't always think about physical therapy having that specialty, but we just happened to work with one, and she was very good at wound care. So how do we get, this diagnosis for the debridement to be done? You're probably not going to be able to just grab it from the order that came over, not only because a lot of times that information's not put on there. I know it's supposed to be, or you're supposed to have that continuation of with care and everything. You're going to have to go back and request records from the GP or whoever's sending them to the wound care clinic. Now, with providers, with people having things that like PPOs, they don't have to have a referral, right? So that can make a big difference on getting the documentation. But you need to know in a wound care clinic, what was the reason for the wound? Was it a spider bite? Is it a diabetic ulcer? Or was it just a non-diabetic that had stubbed toe that just got really massively infected and they have poor circulation, but diabetes is not involved? Things like that. So to be able to get the the information for the proper diagnosis code, you're just gonna, if it's not on that information where the order's written, and a lot of time it's lacking, then you're going to have to request the records, and you're going to have to abstract it from that. Now, from a billing standpoint, I know that Jennifer can probably state how, if that proper code is not put on there, then you're not going to get paid for the service of doing a debridement. So in other words, if a person has a fractured toe and they're going to go in and have debridement done, well, why would they have a debridement on a fractured toe? That's not going to link up, right? That there's no medical. However, if they have a fractured toe on a person that was a diabetic, that it ended up with a wound that opened up, then that makes sense, right? It's not the fact that the person had a fractured toe, it's the fact that the patient had a fractured toe and have diabetes and developed a wound, right? See, so or even an open fracture versus a closed fracture. So you're not going to do a debridement on a closed fracture. There's no wound to do that with. And so you've got to make sure they line up. And the biller, I would assume, is going to have to be very savvy with that. And that's why it's so important that billers and coders are, if you're a coder, that you understand the billing, and if you're a biller, you understand the coding. So it's good to have, if you can get both credentials, to absolutely get them, but you got to speak the same language so that you can say, hey, there's no way we're going to get this paid because a fractured toe is not going to be needing debridement. We need more. So I hope that answers your question. Okay, something else came up over there, but anything else you want to add to that, Jennifer?
Me? No.
So just call for the
Wound
medical
care is
record.
not my thing.
Oh, I
Sorry.
love wound care. Goes right in with that ER stuff. The more gory and unique, the better. Okay, here we go. Was hoping to get help on coding billing for physical therapy. Man, I've been working a lot with physical therapy because we just did a lecture on auditing for physical therapy. And then Jennifer and I were talking about it. Okay, so 97530 therapeutic activities and 97110 therapeutic exercise with mods and GPXP appended to both. Claims are being denied due to 236. Is that supposed to be N45?
Well, a CO45 is an adjustment, so that's not a contract. That's not a valid denial code. I'd have to see what the other actual codes are. A 45 is a contractual adjustment, but that one I know. I see it every single every claim. Is it with the procedure and mod combo? I used to bill 97530, 97110 physical therapy all the time, but this was back 15 so years ago. We didn't need a modifier on either of them. What is a mod? I don't think I have the right book in front of me. What is a GP? I'd have to go look them up.
Oh,
I don't have a heck.
I'm gonna say if I try to look them up, I won't be able to do it on my computer. Are you able to?
No, I got it.
Monitor. While she's doing that, Tiffany and I were talking about this because she was creating some exam questions for us, and we were talking about physical therapy and notes actually this afternoon. And a lot of this stuff is time-based and stuff, so it's really unique to code for physical therapy.
I really liked it when I did it. I really enjoyed it. GP indicates that a physical therapist services have been provided. It's commonly used in inpatient and outpatient multidisciplinary settings. Used for functional limiting reporting. Use this modifier in any case where there could be a confusion as to which provider delivered the services to a patient, such as in an interdisciplinary therapy setting. So to me, I read that as it's not necessary unless you have multiple disciplines in your physical therapy and the patient was having multiple things at one time. KX After the patient has exceeded their Medicare threshold, then you bill the KX. So they're out the year, they require therapy for perhaps something else. Say they had a hip replacement, had lots of therapy, and now they have a new problem. And so they've exceeded that threshold. So the therapist bills it to justify that continued care.
That makes sense.
But I would, so that one I can see being on something because, yeah, they've gone past, the Medicare patient's gone past, and that's Medicare. You're not going to use that with any other insurance companies. But the GP, only if you have other people doing those services as well. I wouldn't see needing the GP modifier unless you're in an unless you're in a multiple discipline setting.
Yeah.
But that could be, if you're using both of them on the same claim, then yeah, that could be why they're denying. Yeah.
So this might be something that we can do some topic requests on, more information on physical therapy. So the course that we just finished opting was, the last one was good. We did that.
There are so many changes right now coming up with physical therapy. The biggest one is physical therapists will now be MDs. Physical therapy is now a doctor program.
They have one? Wow, I did not know that.
No, all of them will now be credentialed.
Oh,
it was a bachelor when I first wanted to go into it, and then it became a master at that time. Now it's a MD PhD level.
I knew that they had a master's degree because that's at the hospital way back in the day, that you had one, the supervisor, the person that ran the department, the physical therapy, because they were right across the hall from us in our department. We were always in the basement, and they almost everybody had a bachelor's degree, but the person that ran had a master's. But wow, okay, so that's great. It looks like that's the questions that we've got. Don't forget that you can see us on YouTube. We have we have over 1,000 videos. We have over 3 million views, and we want you to like and subscribe on our Facebook and YouTube. But for our YouTube, don't forget to hit the subscribe button. And now I think there's that little bell that they tell you about. If you click that, every time that we do something live, which was multiple times a week, sometimes more than one day, you'll get a heads up. So that's a good idea. And then also, if you want some other reference links, we have other webinars and things that we can access. But our Facebook is, don't forget to find us on Facebook /CCO.US. And I know for a fact that when we go to HealthCon, we'll do a lot of Facebook Lives, because last year I learned how to do that, and I was kind of nutty about it.
You're gonna label it before you start, right? You're gonna
and
tell
then
us.
Boyd sent me a message. Did you know you can say, you need to tell us what you're going to talk about? It's like, I just came out of the bathroom and I saw so-and-so.
Facebook Live is like, what was this about? I don't know.
Yeah.
Anyway, thanks for being proactive.
I did look up that denial code. That 236 is this procedure or procedure modifier combination is not compatible with another procedure or procedure modifier combination provided on the same day. So those two codes with those two modifiers, those modifiers can't be used together. So yeah. So
good deal. If you have a topic request, like say you want us to do some more information on those modifiers with PT, just go to, again, the CCO website /topic, use the little hyphen request, and
or you have a question
contact.
What the questions are for your interview. I think that was one that was going to take a
I
while
saw that.
to
that was one. Yeah,
I see that. That's a good one too. Okay, and then not only do we have topic requests, but we also have case study submissions. So let's say you're out there, well, this particular one with the PT report, you can redact that, send that in, and that gives us all the information we need to really come up with a better idea. And then we'll turn around and share that with other people so that it's an educational process for everybody. So again, go to the website if you want, cco.us, up there at the top for contacts, and then this is a whole list of things that you can do with us. Also, just adding more things that we do. If you are a local chapter and you're struggling finding guest speakers, we do that all the time. So we've been doing this long enough that we have, you know, chunked up, Boyd's divided up some of these things, these topics that we have, and made them to where you can air them. They already have been approved before, so they'll get approved again for you to submit for CEUs. And it's all labeled, how long it takes and everything. So if you need a remote presentation, we give that to local chapters free. So here's some of the topics that we have done. You can go look at those. And we like to get a picture of you guys so that we can share that with everybody else. Don't forget to do that survey that we gave you the address for. Let us know how we're doing. Don't forget about the CCO Club and CCO Club Prime. If you have any questions about it, just go to the cco.us, you know, /club, and there's lots of FAQs, and I think that's more links on the next one, which I've already showed you, and then at the very end you get to see all of our shining pretty faces.
There is a handout of all the slides here that I attached in the webinar if you haven't got it already. So unfortunately, just the CCO Club members get the answer sheets, but you can get all the links and everything else. Awesome.
So, thanks, guys.
Thank you, and apologies again for everybody with our early start for some of us, normal start for others. But anyway, we always appreciate you guys coming through and being on our webinars, because it would be very lonely if we did this just for ourselves. Pretty much.
And our diehard people that knew it was 8 o'clock, no matter what it said.
Right.
That's right. They know us well.
We start to lose it after 9 p.m. So it'd be very rare. It'll be 9 p.m. All right. See you guys.
Yeah.
And until we meet again.
Bye.
Bye, guys.